Good afternoon. Welcome to our first in a series of webinars entitled Honoring Indigenous Elders, Building Community Partnerships to Support Care. Today's webinar is titled Partnership Opportunities to Support the Health of Indigenous Elders. Before we begin, I'd like to recognize that this virtual event is taking place throughout the unceded territory of the United States of America and its territories. We would like to honor all the ancestral stewards of this land living in over 1,000 tribes, nations, bands, pueblos, communities, and native villages in the continental US and Alaska. We also acknowledge the Kanaka Maoli of the Hawaiian Islands, the Indigenous peoples of the Pacific Island territories, and the Taino of Puerto Rico. As we begin this event, we acknowledge and honor the original inhabitants of our various regions. If you'd like to learn more about the lands you inhabit, there is a link on this page, and Megan will place that in chat. My name is Linda Edelman, and I am the Program Director of the Utah Geriatric Education Consortium at the University of Utah. At the University of Utah, we acknowledge that this land, which is named for the Ute tribe, is the traditional and ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. The University of Utah recognizes and respects the enduring relationships that exist between many Indigenous peoples and their traditional homelands. We respect the sovereign relationship between tribes, states, and the federal government, and we affirm the University of Utah's commitment to a partnership with Native nations and Utah urban Indian communities through research, education, and community outreach activities. So we are here today through the Geriatrics Workforce Enhancement Programs, or GWEPs or GWEPs. We all use a different acronym for them. The GWEPs are 48 HRSA-funded workforce development programs across 36 states and 2 territories. The purpose of the Geriatrics Workforce Enhancement Programs is to improve health outcomes for older adults by developing a healthcare workforce that maximizes patient and family engagement, and by integrating geriatric and primary care. The GWEPs have a number of goals. First, to educate and train the primary care and geriatrics workforce to care for older adults in integrated geriatrics and primary care models. And second, to partner with community-based organizations to address gaps in healthcare for older adults, promote age-friendly health systems and dementia-friendly communities, and address the social determinants of health. The Indigenous Peoples Consortium is a network of GWEPs working together to improve care for American Indian, Alaskan Natives, and Native Hawaiian or other Pacific Islander older adults through culturally centered education and training that honors their traditions while improving health outcomes. Today, as I said, is the first of 4 webinars that the Indigenous Peoples Consortium has planned for the following year. We're really excited today to talk about partnership opportunities to support the health of Indigenous elders. And our speakers are Bruce Fink and Valerie Jones and Jolie Crowder from Indian Health Services. We were excited to have Tammy Reed from Uniting Nursing Homes and Tribal Excellence, or Unite, join us today, but she is unable to attend. Before we hear from our first presenters, though, I would like to add some Zoom etiquette. First, please keep muted until speaking. Second, please share your name and email where you work in chat if you are willing. And we will be monitoring the chat room closely. So any questions that you have, place those in chat. We hope to have time for discussion at the end of the symposium. And if you have questions then, please raise your hand or state that you have a question in chat and we will get to you. And then finally, please complete the evaluation that we will be adding to the chat toward the end of the symposium. So now it's my pleasure to introduce Larry Newman. He is an assistant clinical professor at the University of Iowa. home of the Iowa Geriatric Education Center. Larry is a dual certified nurse practitioner in adult gero primary care and psych mental health nursing. He is the director of the University of Iowa Adult Gero Primary Care Nurse Practitioner Group. Larry will introduce our first speakers. Welcome.
Thank you, Linda. Yeah, I'm excited to introduce the speakers today. And our first speaker is a family physician and geriatrician with the Indian Health Service. And he's been there since 1991. And for over 20 years, he's provided policy and program leadership in geriatrics for the Indian Health Services and supported tribal, IHS and urban programs in the development of improved clinical and preventative care for elders and in the development of long-term services and supports. So it is my pleasure to introduce Dr. Bruce Fink.
Oh, I'm off mute. Good afternoon. I think we're afternoon everywhere now, including to our colleagues in Alaska. I'm going to begin the presentation. We'll be co-presenting with Valerie Jones. Jolie Crowder is going to be present with us and may be able to we may phone a friend and ask for her help, but Valerie and I are going to be carrying the load today on the presentation. I think Valerie will share slides in a minute. And as we get those slides up, I want to sort of confess to you all that we have an agenda here. We come with an agenda, and our agenda is to have an opportunity to share possibilities for partnerships. Partnerships with you'll see there's a lot of work going on in tribal communities, a lot of interest and a lot of work to address dementia and Alzheimer's disease, but also in a lot of really incredible work going on in tribal communities around elder care, building improved care and services, both clinical and community-based. This is a chance to talk about what are some opportunity partnerships to support that work. So with that, I'll go on to the next slide. The way we thought we'd put this together is we'll start by introducing the team. Then Linda and the organizers of the meeting thought it would be helpful to give a basic overview of Indian health and some of the sort of salient features. I can see already by the folks chatting into on the chat that there's a lot of folks here who have a very deep and sort of knowledgeable understanding of Indian health. So for those of you, we'll move through quickly, but we'll just touch on some key points. We also thought it might be helpful to share a bit of the opportunities around workforce development in Indian health, as you all are often interacting with students, with Native students and with students with interest in Indian health, and we'd like you to know what, be able to sort of point them in the right direction to Indian health, to some of the really important opportunities there to advance their careers and bring them into the workforce. And then we'll close out by talking about the newly established IHS Alzheimer's grant program and some opportunities coming up for partnership with tribes through that program. So we'll go ahead on now to introduce the team. I think Larry introduced me already, so I'm not going to say more than that. I'll give Valerie an opportunity to introduce herself, and Jolie, if you're in a place where you can pop onto the audio, we'll let you introduce yourself as well.
Hi, everyone. I'm Valerie Jones. I am the Elder Healthcare Data Coordinator within Indian Health Services for the headquarters. I am from the Navajo Nation and previously served as the Navajo health service administrator for our aging programs with the Navajo Nation for the Navajo Department of Health. And then prior to that, also worked with Arizona Medicaid, overseeing the Arizona Tribal Long-Term Care System there. And that's just a quick overview of me, and just pass it on to Jolie if she's available.
Yeah, hey, how are you guys doing? I see lots of names out there that I'm familiar with. So my name's Jolie Crowder, and nursing background, and worked with I² for the last 10 years, and am excited to have moved over to IHS to help lift up all of the great new work that we're doing in this space. And so I'm excited to work with you guys and hear about the good things that you're doing, and then share all the good stuff that we have planned coming up. So.
All right. And Valerie, the next slide. Thanks. One of the folks you're not hearing from is Dr. Marcy Roniak, who's the division director at headquarters in the Division of Clinical and Community Services. And Dr. Roniak is really the sort of senior, has been the guide to the development of this program. It sits within her division, but more than that, she's really has a sort of a vision and a passion for care for the elderly, and we're really grateful to have her as our sort of senior leader on the team. The other thing you need to know about the team is it's brand new. So up until, the IHS Alzheimer's Grant Program was funded in the 2021 congressional appropriations to IHS. Prior to that, we did not have dedicated funding specific for elders or elder services, elder care. So you're seeing a program just at its infancy. We're excited about the work that we're going to be talking about, and we're excited about where we can go with this. Go on to the next slide. Just really briefly, again, most of you are familiar with Indian Health, and this is a statement of sort of the Indian Health mission and vision, and that our job is to we're the agency within Health and Human Services with primary responsibility for the health of American Indians and Alaskan Natives. The historical and legal basis for IHS goes back really through the government, is in the government-to-government relationship between sovereign tribal nations and the federal government. And there's a set of statutes, the Snyder Act initially, the Indian Healthcare Improvement Act and its various reauthorizations, including the permanent reauthorization in 2010, that set sort of the legal framework. There's a number of court cases there too. But what's important, I think, to say about that is that it's with our relationship in Indian Health. The basis for our work in the Indian Health Service is in that relationship between the federal government and sovereign tribal nations. The next slide. So there's also a set of statutes also that address self-governance, self-determination in the spirit of tribal sovereignty. So that when we talk about IHS appropriations, what we're really talking about is money that Congress appropriates through the IHS, both for IHS services, but also for tribal and urban Indian health, tribal programs and urban Indian organizations. Today, over 60% of IHS appropriations are administered by tribes through these self-governance agreements and contracts. These tribal programs, so what you have in the IHS is a system of sorts, and that system is made up of three components. There's the federally direct Indian Health Service, which is, often people speak of the system in shorthand as Indian Health or IHS, but in fact, IHS is not the majority of services. We do provide direct services to tribes when tribes elect to have us provide those services directly as in fulfillment of our obligations out of as part of that relationship between the federal government and tribes. but the majority of resources that are appropriated through IHS go actually directly out to tribes for tribally owned and operated services. And then there's also a portion of those appropriations that go to urban Indian organizations that operate urban Indian health programs. Overall, we serve, I'm sorry, one step back actually, Valerie, I was gonna say we're serving 2.6 million IHS beneficiaries. These are federally recognized, these are members of federally recognized tribes and their descendants. And tribes control membership into their own citizens. So when we say they're members of those tribes, that's not a federal determination. That's a tribal determination, who is and who is not a member, a citizen or a member of a given tribe. And then we mentioned before about 41 urban Indian organizations that operate health programs as well, that range from social services and supports and behavioral health, all the way up to full primary care, ambulatory care services, as well as some integrated public health services. Now we'll go on to the next one. Thanks. This gives you a sense of kind of the structure or the delivery system, right? About 24 IHS hospitals, 22 tribal hospitals, way more health centers on the tribal side. Most of the IHS health centers, many of the IHS health centers are associated with hospitals, but not all. There are many freestanding health centers as well. Health stations are programs that have less than 40-hour-a-week full sort of coverage. So that captures some of the school-based programs. And for example, Alaska Village clinics are kind of a unique structure. And then youth regional treatment centers. Of the 46 IHS hospitals, or 46 IHS and tribal hospitals, 14 of them are critical access hospitals. So that reflects the fact that our system is largely rural, and these are by and large smaller hospitals. Our largest hospitals are somewhere in the range of 150 to 200 beds. So, just so you're aware, IHS is divided up into 12 regions, and there are many tribal components that are also operate within those regions. So, for example, that each IHS region also has a tribal health board, which represents elected tribal leadership, and together they so there's as well a national Indian health board that reflects all 12 areas. So that the 12 areas are kind of administrative centers. They began as federal administrative centers, but they kind of structure a lot of the Indian health relationships, the relationships between tribes and IHS and even tribes and each other through the health boards in those regions. The next slide. This is an old map of. It's now. I bet this is. I'm gonna say 15 years old, but that probably means it's closer to 20. And it's a little out of date if you look, and it's good that you can't see the fine print because there are new programs, including the newly recognized but very old tribes in Virginia, for example, that are reflected on this map. But this gives you a sense of where Indian country is from the perspective of federally recognized tribes served by the Indian health system. So it just gives you a kind of a feel for the density and sort of location of tribal communities and tribal services. The next slide. Actually, before I go on, I'm going to hand off actually one slide. One of the characteristics of the Indian health system so a couple of key characteristics of the system that are worth mentioning that we haven't yet. One is that it's largely a primary care health system. So most of the services provided directly, either by IHS, tribal, or urban programs, are primary care services. There are some specialty services, both on the IHS and tribal side and on the urban side as well, although fewer there. But for the most part, specialty services are purchased from outside of the Indian health system. So when we talk about the Indian health system, we're really talking about a system of primary care. And in fact, we're talking about a system of primary health care, because one of the unique features of the Indian health system is the integration of public health and clinical services. So there's a public health component to Indian health, and this is manifested both in terms of the sanitation and environmental health services that are integrated into Indian health programs. It's manifested as in the workforce development that we'll hear about in a moment, but in the integration of public health nursing and community health representatives in the system. So it's sort of unique in this country in the integration of public health and clinical services together. And then finally, and this many of you know, it's largely a rural system. That there now 70% of all American Indians, Alaska Natives live in urban communities, but the structure of the healthcare system is more rural than urban, serving large, and much of it is frontier rural as well. So that carries with it all of the unique features of rural healthcare delivery. So, and now I'll turn it over to Valerie to talk a little bit about some of the workforce development opportunities that are sort of built into Indian health.
Thank you, Bruce. So the Indian Health Service Division of Health Profession Support, DHPS, lives in the Indian Health Service Office of Human Resources. Division of Health Profession Support is responsible for recruiting and retaining health professionals to serve within the Indian health care facilities. Their overall strategy is to provide and administer scholarships, externships, loan repayment, grants, and other career support services. They also try to promote the services of its dedicated healthcare professionals and the American Indian and Alaskan Native communities they serve. So the Division of Health Profession Support administers programs designed to encourage American Indians and Alaskan Natives to pursue a health professions education in the fields of medicine, nursing, and psychology. Recipients serve in the federal, tribal, and urban programs, as Dr. Fink just highlighted. So what programs do they oversee? They have the loan repayment program. It is a program in which licensed clinicians secure a job with an IHS and apply for loan repayment. This program is not limited to American Indians and Alaskan Natives. Awards go to areas of greatest need and areas with larger numbers of health professionals. As for the grants, there is the Indians into Medicine program, American Indian into Nursing program, and American Indians into Psychology program. The American Indians into Medicine, Nursing, and Psychology programs partner with a number of colleges and universities to provide financial and/or educational support for American Indian and Alaskan Native students interested in practicing as clinicians in any of these professions. The Indians into Medicine program encourages and assists American Indian and Alaskan Native students in preparing for a career in healthcare. Through grantees, the program provides greater exposure to careers in healthcare, offers tutoring, career counseling for students, assists with financial aid, scholarship applications, and they also host summer educational sessions. So they are very busy. The American Indians into Nursing program helps to increase the number of nurses, midwives, nurse anesthesists, and nurse practitioners who deliver healthcare services to the IHS population. And there is a growing need for clinical psychologists within for IHS populations. hence the development of the American Indians into Psychology program. Scholarships are available to undergraduate and graduate students pursuing psychology degrees. And the key components of the health profession support efforts are recruitment and retention. The team works to create a culture where people want to stay for a long time and contribute to the overall team, make IHS their career, and be critical players in the shared mission. Our Indian health practitioners work alongside our dedicated providers to ensure comprehensive, culturally competent care that honors and complements the traditional beliefs of tribal communities. And as far as the Uniform Services of Health Science, another program that's within the health profession support, each year IHS sponsors students to go to the to the program, and their mission is to train, educate, and prepare uniform service health professionals. And the physicians are trained in several primary care specialties and provide direct health care and disease prevention services. The education is at no cost to the students. Participants still draw a full salary and rank as a junior officer while attending the four-year medical school program. In return, graduates commit to working for IHS in a high priority site. And here is a picture of our Division of Health Professions team within IHS, and their website information is here if you want to contact them for any questions. Now I'll go on to the next slide. So within our work, as Dr. Fink mentioned, we are developing and building out our program, and have, heard some stories so far. I think some of us have some personal stories to contribute as well. And we just thought we'd highlight this individual story. And I think Dr. Fink has some background to this story here. So I'll go ahead and let him provide that. And then I can read the slide, Dr. Fink, if you'd like.
That would be great, Valerie. Yeah, Kathleen Marquardt wrote this for us now almost 20 years ago, and it was published in, at the time, sort of a journal that was circulated widely in Indian health called IHS Primary Care Provider, and it just, as Valerie said, it anchors us in what we're trying to do here. So I won't say more than that, but these are Kathleen's words about her mother. And I'll let you read it. Thank you,
Okay.
Valerie, for reading it.
Thanks. Now, at times, she thinks that Dad is out fishing and will be home soon. In some ways, this is good because she does not always have to know that he is gone and continuously have to suffer the pain that loss can bring after a lifetime like theirs together. But there are many times that she is totally lucid and knows that he is not with her, but is waiting for her to be with him when her time comes too. We have, as a family, kept Nana in her home, in the surroundings most familiar to her. There, every day, she is close to all of her family who love her and accept her wherever she may be mentally. She knows that she is home and that she is safe and loved, despite her confusion.
Thank you, Valerie. That's I know Kathleen would love to hear you read that. And Kathleen is from Alaska, the Tlingit tribe. So now we'll go on and start to talk a little bit about the IHS Alzheimer's Grant Program and kind of what we're trying to do and what the opportunities, what we're trying to create in partnership with the tribes and urban Indian organizations. I mentioned we first received funding in the 2021 budget, $5 million. We received a second funding in 2022. This is not, it's not appropriated as continuing funding. So we very much feel the responsibility to make sure that this money gets put to good use, gets into Indian country in a way that changes that impacts people's lives, we know that's the best way to make sure that these resources continue. As we do in Indian Health, when we receive a new appropriations or new funding, we have a process of tribal consultation and urban confer, where we go to tribal communities, tribal leadership, to get a sense of guidance about how these dollars should be spent. And we did that. Unfortunately, it was virtual because this was during the pandemic. Often it would be more of it would have been in person, but we were limited to virtual meetings last year. And out of that, we kind of developed 4 buckets of work, 4 areas of work that of work for the program. The largest bucket of work and the largest area of work is really to get funds out into tribal communities so that they can begin to develop services for people living with Alzheimer's, with dementia, and their families. And it's not just, and this is $5 million doesn't go very far. So what we're trying to do with these dollars is develop models of care. And and the strategy here is based in the understanding that tribes will take the evidence that's out there about what works and what doesn't work, and then they will apply it and build programs in their communities that are responsive to the needs of those folks in their communities living with dementia and their families and caregivers, and that they're really the only ones who can tell us what's going to work in their communities. So that's sort of we have a set of grants and program awards, grants for tribes, program awards for IHS services that are providing direct services to tribes, to begin to develop models of comprehensive care for people living with dementia and their families. We heard very clearly in tribal consultation and urban confer about the need to build capacity and capability in our clinical services around dementia. And this isn't unique to Indian country. You hear the same. I represent IHS on the National Alzheimer's Advisory Council, and we hear the same thing coming from outside of Indian country, that folks with dementia or with cognitive impairment or complaints or concerns come to primary care or even to specialty care and don't receive the services they need, aren't able to get to a timely and accurate diagnosis, or receive a diagnosis, and as someone said at a recent NAPA meeting, diagnosis and adios. Don't receive services that they need to actually manage the condition. So we're building a large pillar of work to support the grants and program awards in education and training. And part of that, and we'll talk more about what we've got going now and what we hope to have over time. Part of that is clearly around caregiver support, coaching, and support and coaching for caregivers. We're fortunate to have in the Indian health system some workforce that bridges between clinical and community services. So public health nursing and community health representatives. They are in the homes of elders and others, and we're operating under the sort of strong bias, I will say, and the clear vision that care for a person living with dementia includes care for the caregiver. And so part of our training and education is around caregiver support and coaching as well. And then while the last 20 years have been remarkable in the increase of awareness and understanding of dementia in tribal communities, and I think many of you all on the phone are part of why that's occurred, whether that be through IA Squared, through the university outreach, through the GECs, and now the GWEPs, through Alzheimer's Association, through the National Indian Council on Aging. There's been a lot of work done to sort of raise understanding and awareness, but we still have more to do. And in particular, we're interested in developing touch points into tribal communities. Folks who wake up in the morning thinking about how to improve care for the elders and how to improve care for people living with dementia and their caregivers, and to support those folks with training resources, education resources, make sure they're aware of funding opportunities that come along. So that's the outreach and dementia awareness pillar. And then the basis of that is the headquarters program, working the staff that you see here, but also developing some data resources to help support tribal programs as they start to think about what they want to do, how to meet the needs of their citizens. Our data approach is not a primary research approach. There's that we heard very clearly from tribal leadership. They think that what they're interested in seeing is us using the data that we have in the Indian health system and making that available to them to help them with their work, rather than do sort of primary, research. There are other arms of the federal government that have responsibility for that, at NIH and around public health at CDC. So our work is going to be largely about taking data resources that we have in our clinical information system and elsewhere and making them available and useful to tribes and tribal communities. Go on to the next slide. So this is, I mentioned the tribal grants are the biggest piece of the work. And this is just part of the language from the initial funding announcement. And we've asked tribes to be bold and to be ambitious, and really to say, to think about what would it look like if they were able to provide a comprehensive set of services for folks living for their citizens living with dementia, and recognizing that over the life of a 2-year grant or 4 years, you can't build an entire system, but offer them the opportunity to have that larger vision and then pick some pieces of it, and they get to decide which pieces they want to start with, to start to implement over the 2-year life of the initial grant. The other piece to this is that we ask them to share with us what they're doing and what they're learning, because these are models, and we hope to be able to share, help them share what they're learning and what they're doing with other tribes, to encourage other tribes on their journey and to support other tribes on their journey. And finally, $5 million doesn't go very far. So we know that many of these services are going to have to tap into existing funding streams. So we'll be working with them to sort of identify the funding streams for the programs that they develop through this grant program. The next slide. These are the 4 pioneers of the 4 tribes that have really stepped forward to take the first cut at this. We met with them recently. They all said, they've been thinking a lot about how to improve services for the elders, and in particular for dementia. They had a lot of ideas, and then this funding opportunity came along, and they grabbed it and ran with it. Many of them have have existing partnerships that they're working with, and that's terrific. We've got we're on the slide, you'll see some of the things that they're planning to do. They're really just getting started. These were just awarded in this fall. So they're just getting off the ground, and we'll have a lot more to share about what they're doing over time. We know that we anticipate being able to fund another cycle, another cohort of grantees next year. And we know that some of these grantees won't have as well-developed set of ideas as these grantees do. And they'll be looking for partnerships and for expertise. They'll be looking for ideas. They know what their citizens need, but they'll be looking for partners who can sort of help them think about how best to take the existing evidence and translate it into what their citizens need. Next slide. On the training and education front, we've started in 2022 a sort of an Indian Health Geriatric Scholars pilot. This is patterned after the very successful VA Geriatric Scholars program that's now, 10 or 15 years old. And what's really, what drew us to the VA model is that it's specifically intended to build expertise in the primary care workforce in the VA. And that obviously is a need that we understood as well. We started small. We said we're going to try to recruit 8 individuals, either providers as in NPs, PAs, or physicians, and or pharmacists. But we had a much greater response. We had 19 folks initially respond, 17 of whom are continuing on, and we were able to bring them all into the program. So we started much bigger than we expected. This is the first year. Each of them, in addition to receiving training, is starting to look at how they can improve services in their own facility. And they choose, again, they are selecting, they're identifying the need and selecting the projects or the effort to improve services, and we're working with them to do that. And they're just getting started on that work. We do part of the VA Geriatric Scholars Program that we'd like to replicate. We're really trying to adhere as closely as possible to the VA program, just because it's been studied and shown to be successful, is a mentorship or a practicum experience. And that's going to be a lot harder for us in Indian Health than it is in the VA, because we don't have the depth of geriatric resources available. And you can imagine, we'll talk more about that in a little bit. We've also started a dementia echo with Northwest Portland Area Indian Health Board. They've really started this, and we've been in partnership with us. It's been something of a soft launch this year to gain experience, and we will be expanding that in 2023. We'll talk more about that in a minute too. We're just initiating a project with the Division of Oral Health, our dental services that are integrated into the clinical services and in IHS facilities. They're going to be working with a small group of facilities that want to test how to build recognition of dementia into oral health services. And the concept here is not that they are going to be screening every person who comes in for dental care for cognitive impairment, but that they're going to have the tools and knowledge and workflows established so that when it's to be able to test for cognitive impairment in elders who may, or in individuals who may who are at risk or may show clinical signs of potential cognitive impairment, and then be able to both address cognitive impairment within their own services, but also help those folks get to a diagnosis and get to services. So this is just getting off the ground. We'll be starting with those groups in the new year, and we're excited about that. There's a project of the Division of Nursing that we're helping with around geriatric emergency department accreditation. This is the IHS Division of Nursing is doing this work in partnership with ASAP, the American College of Emergency Physicians, and supported by the Johnny Hartford Foundation and the West Foundation. And they're working with 11 tribal and IHS EDs to develop the first level of geriatric ED certification. Those EDs are working on things like fall prevention, dementia detection. They're making sure that they have supportive services available and in the ED and assistive devices, that they're ambulating elders in the ED, whole set of activities that make them more elder friendly and really able to provide geriatric specific care in their ED. And then we're starting to build out resources for training, where we've got more to do in this regard, but our first cut is to link to existing resources through the IHS website. So we've linked to the current HRSA dementia curriculum that you all know very well, but also to the VA training that's available through the Train platform. So we'll go on to the next slide. So what's coming up in the next year, and what are some of the opportunities? We do expect to be able to have a second round of grants, and we're excited about that. And we want to be able to get the word out early and spread it far and wide, and give tribes plenty of opportunity to start to think about how they can do this work. We're also going to be looking at program awards to IHS facilities serving direct service tribes, so that they also can start to think about how to improve the services they provide to their community in partnership with the tribes they serve. We hope to recruit a second cohort of geriatric scholars. We really see this as and potentially to expand who is eligible for application. We started, as I said, with providers and pharmacists, and we may be able to expand beyond that. We see this as a really important way to start to reach out and build capacity in IHS tribal and urban Indian organizations for geriatric care and for care with of folks living with dementia. And as I mentioned before, we hope to continue the partnership with the Northwest Portland Area Indian Health Board and sharpen the focus a bit of the ECHO program into two specific areas. One is around the clinical diagnosis and management of dementia, again, as a support to the workforce in our facilities. And the second is to provide support to staff who are supporting caregivers, so that those folks also have additional support as they go out into the homes of folks living with dementia and their caregivers. The next slide. So this gets us to where we wanted to get to at the very start, which is what are the opportunities for partnership? So we will make sure that you all know about the grant programs that when it's published, hopefully in the spring, and we to the degree that you have relationships with tribes, to give you an opportunity to reach out to those tribes and sort of offer support to them if they're make sure that they're aware of these opportunities, and potentially offer support to them in their applications. We think there's a real opportunity around the practicum mentorship component of the IHS Geriatric Scholars, and a way for you all to build relationships with the champions in those IHS urban and tribal organizations, champions for improved clinical care in those organizations. I'm sure that the Portland Area Indian Health Board will be looking for dementia for faculty, for the Dementia ECHO, faculty particularly that has experience working in tribal communities and with tribes. And as you strengthen your partnerships with tribes, that makes you prime material for faculty for the ECHO as well. And I know we've talked with Joan Weiss and Ina Tomosa about some of the work you all are doing around training. And we know that that's a big component of the work that you do. And we'd love to be in a situation where we could sort of link folks to your training materials and get broader reach. Again, particularly training materials that are designed for and attuned to the needs in tribal communities. And we know for example, many of you have, or not many of you, but some of you have developed those materials, and we're excited to be able to link to those and help make those, put those into use to improve care. Those are our ideas, and now I'm going to shut up and listen because we'd love to hear your ideas as well. Valerie, is there anything else that I missed before we go on to questions that you wanted to add, anything else that I sort of missed?
No, I think you did great. We were just curious about the feedback from folks around how they would like to assist, our health facilities across Indian country.
Hi, I'm Deborah. I'm with the Alzheimer's Association in the Wyoming chapter, but I'm wondering, Bruce or Valerie, are you already connected to our health systems team? Is that a relationship that you have already, or is it something I could help facilitate? Tell me a little bit about your relationship with us, because a lot of what you're doing is definitely aligned with, what we're wanting to do both locally and then, of course, across the nation.
Yeah. The Alzheimer's Association has been a terrific partner for Indian Health and a really strong advocate for increased attention to dementia in tribal communities. And I just need to sort of call that out. We have been connected to the health systems folks and connected also through Edie to the chapters as well. We've developed a memorandum of understanding with Alzheimer's. I mean, that's part of, sort of really in recognition of their role and the importance of this partnership. And are excited about the idea. Definitely recognize that chapters are a really important resource for tribal communities that in their states, in their district. And I know of at least one tribe that was, they didn't end up applying for the grant, but was working with their chapter, their local Alzheimer's chapter, at least to develop some ideas around that. So we think that, that sort of those connections between the Alzheimer's chapters in particular and tribes can really be important partnerships too. Thanks.
Great. I'll put my contact details in the chat. And then also I would really want to include Rosalind Reese, who's our DEI lead for our region as well. So if you're not connected to Roz as well, but we'll definitely be interested in our work here in Wyoming. But I know across, like you said, I was on the work group before that was initiated. It was really quite a great learning space for us. So thank you for what you're doing.
Thanks.
And if you'd like to join our listserv, I just put it up in chat.
Yeah, thank you for doing that, Valerie. I'm glad you thought of that. The listserv we didn't highlight is we're starting to build out a listserv, and this is our community, really. This is the community of folks, largely in tribal communities, but also folks interested in partnering with those communities. And it's going to be one of the ways we push out and make sure we reach folks. So please do sign up. You won't be bombarded. There's not a ton, we're being fairly selective in what we send out, but it'll be an important way to stay in touch and stay connected.
Bruce, this is Linda Edelman, and one of the things that I was thinking about as you were talking is that a really great role for the GWEPs, as you alluded to, is to help with the education and training, because that, you're right, the money doesn't go very far, but we do have that support, and many of us have it written into our grants to help develop culturally appropriate materials for Indigenous peoples. So any thoughts on how we could help facilitate that? Is it more within tribal groups, or is it more at the federal level? Yeah, I mean, so I'll take a first stab, and then Valerie, I'm interested in want to have you share your thinking about it. But I think
so the best work I see is in response to the needs of a community. I think when we start to operate at a federal or a national level, we start to get indistinct and blurred in our attention to folks. You know, every tribe is different, every community is different, and folks share resources across communities, but we reach people when people know we know who they are, and they know we know who they are when we speak specifically to them, right? Or to someone like them. You know, when we're specific, and it's like any good story, right? Any good story has to have a lot of specific detail in it. So the specific detail I'll have here is that the Wyoming GWEP, I know, developed an approach to the 10 warning signs for dementia that they worked on with their tribal partners. And even though it's, and Catherine, you could speak to that maybe a little bit after it'd be great to have you speak to it, but even though it's specific in its imagery and in its language to the tribes that you developed it with, I think in its specificity to that tribe, it also speaks to other folks. They recognize in it that it was developed in partnership with the folks it's intended for. So I think that's pretty long-winded way to say, I think the work is local, but that the local work can then be disseminated broadly. I don't know, Valerie, what can you add? You can add to that.
No, I think you're right, Bruce. I mean, this is we're just building this out. So really meeting with the communities at their level and then having them report out as to what their needs are, what their gaps are in services, and then building a model to try to address some of those issues. And I know we're not going to get to everything, but I mean, I know for the most part, elders are so important and essential, in tribal communities. And sometimes, there's a lack of advocacy there for that population. But I think with our work, we're going to highlight more of the stories and address the gaps in services. And as Bruce said, really meet with folks, at their level and go from there together, and to make sure that we are all, succeeding in this.
And I see Brianna Dorami from IA Squared has sort of chatted in the IA Squared link or information. And IA Squared, funded through the CDC, is a bold center. And part of their mission is also to kind of create materials or either to create or more to assimilate, to capture materials that are available. And I think, I think together, what we want to do is see what's available and then create what's needed also. I think we're going to be looking, we're especially tuned in to looking to see what's already out there, we view ourselves primarily as disseminators, not creators in our program.
One of the questions I was asked kind of in the private chat was to talk about the state plans for dementia care. So I can't speak to it all. What we are trying to influence the development of state plans, right? And then of course the bold funding and all those things are all coexisting. Here in Wyoming, I only got to Wyoming in September. So the first thing I did was reach out to the University of Wyoming, the Center on Aging, some of the other key partners that are working in this space. And we will be leading, as part of our work, community forums and outreach intentionally in all communities, but including our Native communities. And, we believe that it's important when we arrive, we ask first, right? And we find out I love that you said there's not one size fits all anywhere within our Native communities, because they're all individual communities and we have to approach it that way. So I think that's also really an important thing to consider when we're building out even curriculum. I lived in a Native overseas in a Native community, and the words we use sometimes aren't even the right words. I mean, the simple a nuance in how a word is interpreted, right? So we have to really localize in specific communities, not broadly that all Native communities are homogenous in themselves, right? I think that's the big lesson, isn't it, for all of us?
This is Jolie. I actually, if we have time and people are interested and willing to share, one of the things I'm interested in is we're thinking about all of these training and educational initiatives is what is already existing and what's working really successfully for you guys. So like we're linking to the HRSA modules, and we've talked to them about how are people actually using those and what does your training look like and what is successful. And so if there are folks on the line who have, small, big, whatever, anything in between about your approaches to training specific to working with tribal communities, but, more generally, if you want to speak to that about very specific curriculums or trainings off the shelf and those types of things, that would be helpful to hear.
Maybe I could just say a few words about the materials that you mentioned, Bruce, in response to that question, Jolie, but I have put it in the chat box, and hopefully I think a lot of people are probably familiar with the materials that we developed in collaboration with tribal members at the Wind River Reservation, representing both tribes. There's 2 tribes on that one reservation. So this is what they look like. This was a very, very iterative process that started with a focus group looking at the Alzheimer's Association 10 signs and asking tribal stakeholders, if you were to change these messages, how would they change in order to speak better to you and to the people that you know? And we got really wonderful feedback around the need for a story, for images, and for the visual enhancement of them. And then also around the actual words. If you're familiar with the 10 signs, you'll see that some of these are different, such as memory and a fog, pulling away from others. So then we worked with Native and non-Native artists to create the images, take them back to focus groups, make changes, and ultimately ended up with a poster, is what you see, I think it's on your left, and then a booklet as well that has additional information in it. We are next looking at doing a similar process around age-friendly. So we'll have some 4Ms materials coming along as well. But again, that's going to be that very community-based iterative process where we really learn how we can create materials that are helpful. These materials have been so well received by tribal members that we think we can use this approach again successfully around age-friendly. And we've had a lot of people in here request materials. The other thing we'll be doing is creating an adaptation guide so that other communities can take these and adapt them, and just know, we know that these are not appropriate. Maybe they are, but maybe they aren't for your community or culture. So look at them, look at certain aspects of them. So some of you on here, we might be working with to create that adaptation guide. If you get a request from us, don't be surprised, but we'd love your input on how we create that guide so that other communities can take these, adapt them, and use them in the future. So that's one way we've been working with our tribes, Julie.
That's great. Bruce, I think you guys have to go. I don't know if you want to offer some closing thoughts.
Well, I have to apologize. We're going to do a little tag team here. Jolie's going to come in to continue the conversation. I'm going to have to step away. I did want to leave one last thought again, which is be interested in, if any of you, Valerie and I both sort of work with the Geriatric Scholars Program, and would be very interested in if any of you are particularly interested in sort of thinking about practicum or mentorship experience with geriatric scholars. It'd be an opportunity to connect with providers or with staff at an IHS tribal or urban program who are trying to build their sets of skills, and you would kind of create a connection with them. Also, that's a way in, if you will, to understanding what's needed at that facility and in that community. So I want to leave that plug with you. If you're interested, to please please reach out, let us know. I'll chat in my email, and I'm sure Valerie will too as we're leaving. I'm going to have to step off, but I'll leave it to Jolie to carry it on from here. So, thank you.
And thank you, Valerie, too. Catherine,
I put my email in there. So if you all have any questions, feel free to shoot me an email. Please sign up for our listserv. Thank you for giving us this opportunity, and I'll leave it with Dr. Crowder. Thank you, Dr. Crowder.
Thank you. Catherine, your guide was lovely. When I was at I2, we created an adaptation of the 10 warning signs as well. And yours was a really fundamental piece in terms of language and thinking and concepts. We even considered, illustrations in the way that you guys had done it that might be more universal. And we didn't quite make it that far, but I do think we have an acknowledgement like to some of the language choices that you guys had on there. So,
that's good to know. We weren't aware of those yet. Awesome.
Yeah. Let me, for you or anybody really, so, that's like a resource, I think, in the process of creating the resource and an adaptation piece, which was really important in our work that I was doing before. But how about training? Like, are you doing training? Is anybody else who's on the phone doing training specifically for or inclusive of tribal providers and those and the like? And if you are, like, if you want to talk a little bit about that, or maybe it's just another conversation we have. It's hard to navigate a conversation with 40 people, but that's a space I think we're particularly interested in, is finding nice models of training that are working and emulating those.
I can just quickly say where we are. So that is a big piece of what we're looking to do in the future. We have been really slowed down by COVID. We were hoping at this point to have some adapted age-friendly materials, and we're really just now probably, getting into where we can get to the meat of that project. So I think we'll get there, but it's definitely delayed for us.
Jolie, this is Linda Edelman. In that question, when you're talking about training, are you talking about clinical training or community? What specific are you asking?
Our focus is going to be for that, if you go back to Bruce's visual, the one on the left, where it was training and education of really all the disciplines sort of in the IHS system. So that could be CHRs, public health nurses, physicians, really the spectrum, if you will, of folks. In that space, and recognizing that might differ a little bit. I know OU Health Sciences Center created a training that was specific for community health workers and CHRs. And so, that to me is like a nice example of, it was discipline specific, engaging, created with the community, or just even like we've created this curriculum and it's worked, or we're using the HRSA curriculum and it's worked, or does it work, that sort of thing. If that helps with clarity of the question.
And I know we do have resources in that space of what we would call more education, targeting different Indigenous populations, because they've been done in different settings. But I think for us, especially in Wyoming, working with university folks and our partners, to first begin with going in and having that local community forum, that's going to be our approach. And then kind of identifying stakeholders within that community to sort of bring in, so that when we are delivering, we're delivering programs with them instead of to them. And I think that's going to be really fundamental to taking what we have, even if it's an adaptation, and then applying it specifically to that local community, right? So I think there's that piece is really fundamental to being successful. And that's just first going in and just meeting with folks, asking them, what do you have? What's working? What's not working? What do you need? How do we support you in a way that's supportive and not imposing? And then as team members on that, responding accordingly. So I know that's our collective agenda, and I'm really excited to see what we can do with that. So I think it's, something I think we are all trying to model at least at the association level, of leading first with a forum and an ask.
Thank you. I hijacked to ask things, but if anybody else has questions or wants to throw anything else out to the group. Quiet. It's after 5 here, so maybe everybody's like
Yeah,
tapped
I
out.
think we're ready to wrap up. Hi, everybody. My name is Michaela Ebrau. I'm from the University of Hawaii. I'm Laguna Pueblo and Quetzon from New Mexico and Arizona. And this has been a really great learning space. I really would like to honor all of the work that you are doing. I am going to take a moment to read our land acknowledgement as an acknowledgement that all of our tribes and all of our populations are different. So I'd like to acknowledge that the Aina that I am on in Hawaii is part of a greater, larger territory recognized by the Indigenous Hawaiians, Nakamauli, as their ancestral grandmother. We recognize that in 1892, Her Majesty, Queen Liliuokalani, yielded the Hawaiian kingdom under duress in protest to the United States to avoid the bloodshed of her people. We further recognize the generations of Kanakamo'oli and their knowledge systems and lifeways that have shaped and continue to care for the land that is Hawaii to this very day. So I would like to take some time to really mahalo our presenters. Thank you, everybody that came. This was a great space of learning, and we are over time, which shows how needed this was. You know, we've been working on these projects for a long time, trying to integrate age-friendly health systems with our communities, and we're trying to find the best way to honor the very varied cultures and ancestries that we have, while really supporting our elders as they are treasures for community and for culture and continuation of our cultural practices. So thank you for coming. Thank you for learning with us. Please take some time to complete our evaluation. This is a quarterly webinar that we are launching, so we will be doing more in the future, and we would love your ideas moving forward as we continue to plan. So thank you.